Hello, all. Greetings, welcome. I'm Cynthia Rohrer, she and her. I'm on Ohlone land in Oakland, California. I'm the program director for EDSP at Bridge. I'm so excited to welcome you. And as folks arrive, please introduce yourselves in the chat so we can begin to connect and welcome each other. We can go ahead and get started with the next slide as people do that. So we are here to share with local health jurisdictions or departments about our ED, syphilis, HIV, and hepatitis C virus screening program, or EDSP. And Paco, I'll have you please go to the next slide. Thank you so much. And we're here to welcome you all. So our invited folks here are from local health departments who are in jurisdictions where hospitals were awarded the EDSP program funds. So let's go ahead and get started. As I mentioned, I'm from Bridge. On the next slide, you'll see that Bridge is a program of the Public Health Institute. Bridge is administering the EDSP funds through our partnership with the California Department of Public Health. And I'll share more about us at Bridge and our mission and vision in just a moment. And we are here today because the California Department of Public Health and Bridge awarded funds to 28 hospital emergency departments in 14 counties across the state to implement or expand routine opt-out screening for syphilis, HIV, and HCV over the next 2.5 years. On the next slide, you'll see today's agenda. So I'll briefly introduce you to Bridge and the EDSP team. And then Dr. Kathleen Jacobson, who, as you know, is chief of the STD Control Branch at the California Department of Public Health, will orient us with a welcome and remarks on EDSP's background. And then Ellen and I will share about the EDSP program, including goals and hospital expectations, and give a brief overview of the awardee sites. And really, the majority of today's webinar is focused on local health department and ED collaboration. So we're really lucky to have some expert local health jurisdiction or department panelists who will share their experiences implementing these programs and partnerships with you all. Ellen will then talk about leveraging grant funding to support this work. And before we have a Q&A. So if possible, we do ask and encourage you to save your questions for the end of the Q&A section. I know that can be hard, but there'll be space to enter those into the chat so that we can have our experts respond. And then we'll wrap up with next steps for you. So, as I said, I want to just share and introduce a little bit about who we are here at Bridge and our vision and mission of treatment, equity, and connection. So EDSP builds on Bridge's health equity model by reaching and linking those most disproportionately at risk and traditionally excluded from systems and care. We connect patients where they are to care and community resources. And our ED clinical champions and patient navigators lead teams to reimagine traditional treatment and address the social drivers of health. You can see in the next slide that the major focus of Bridge's work thus far has been to equip California to address the opioid crisis. So California Bridge was our original program aimed at creating 24/7 treatment for substance use disorders in all California emergency departments. And California Bridge rapidly scaled to implement our model in almost 85% of California hospitals. From 2019 to today, 276 hospitals have implemented the California Bridge model, helping thousands of patients get treatment. And so California Bridge has really revolutionized the system of care by funding and training hospital EDs in a harm reduction approach, in low barrier access to treatment on demand, and in navigator facilitated linkage to care. And I'll mention that all of the sites who received this EDSP funding that you will be partnering with on syphilis, HIV, and HCV work, screening work, have previously worked with Bridge. And in recent years, Bridge saw that we could do more to integrate critical public health interventions into emergency care settings. So we're now spreading our successful substance use disorder model into pre-hospital EMS settings and nationally. And I'm just really proud to be part of this expansion into sexual and reproductive health. So this is through both our ED, syphilis, HIV, and HCV screening program that we're talking about today, and through Access Bridge, which supports perinatal and contraceptive care in EDs. So I will briefly share about the EDSP Bridge team before we move on to the rest of the agenda. As I said, I'm Cynthia Rohrer, she and her, and I'm EDSP Program Director. And I come with over 15 years experience in safety net and community clinic direct patient care and leadership in sexual and reproductive care. And I want to just highlight that part of that work was directing Planned Parenthood NorCal's medical case management department. So I was lucky enough to partner with perhaps some of you with counties throughout Northern California on treatment and linkage for syphilis and other STIs. And Dr. Andrew Herring is one of Bridge's founding directors. He's the EDSP PI and clinical lead. He is an attending emergency physician and associate director of research at Highland Hospital and Alameda Health System in Oakland, as well as medical director of the hospital's substance use disorder treatment program and attending in its interdisciplinary pain management program. We're also really lucky to have LaToya Mitchell as our Navigator project manager. She has over 10 years experience in opioid use disorder treatment through roles such as an MAT substance use counselor, clinic manager, and substance use navigator with Bakersfield Memorial Hospital. And she has also worked closely with the Linkage to Care Navigator on STI work. And Francesca Chiquin is project manager also for EDSP. She is supporting hospital sites to meet and report on their funding deliverables and TA. Francesca, we are lucky to have, she's been at Bridge for 3 years supporting the Bridge Navigator program. I also want to just give a sneak peek and highlight that Bridge will be posting a new part-time clinical implementation leader to support EDSP. So I'm calling that out so that you can get ready to share that opportunity with the excellent physician partners you have in your networks. This role will provide ongoing training, coaching, and academic detailing to participating hospitals to help ensure their capacity to implement and sustain these screening programs. So we at Bridge are really grateful for this partnership with the expert team at the STD Control Branch and who are providing subject matter expertise to support technical assistance and evaluation for EDSP. And so now I will hand it off to them. Go ahead, Ellen.
Great, thanks so much, Cynthia, for that introduction. So for those of you that don't know me, my name is Ellen Ehlers, and I'm an Evaluation and Quality Improvement Coordinator with the STD Control Branch at CDPH. And I'm excited to be co-facilitating this webinar with Cynthia today. As you can see on this slide, there is also a team of folks at the STD Control Branch who will be providing, as Cynthia mentioned, subject matter expertise to support technical assistance to emergency departments and local health departments. And we will also be supporting the evaluation of EDSP. Next slide, please. So with that, I want to welcome and introduce Dr. Kathleen Jacobson, who is an American Academy of HIV Medicine and HIV Medical Association HIV specialist and board certified family physician with over 30 years of experience. Her clinical care experience includes full spectrum primary care, hospitalist and ICU care, as well as emergency room consultations for complex HIV and STI patients, as well as hospitalist, urgent, and ICU care. Dr. Jacobson is currently the chief of the STD Control Branch at the California Department of Public Health and the former chair of the California COVID-19 Testing Task Force. In these roles, Dr. Jacobson has overseen the clinical, scientific, and administrative budgets for California. She is on the board of directors for the HIV Medical Association for the Infectious Disease Society of America, and as the previous medical director of the Los Angeles Region Pacific AIDS Education and Training Center, Dr. Jacobson has extensive experience in workforce development, capacity building, and technical assistance to clinic systems and emergency departments. So now I'll pass it over to Dr. Jacobson. Welcome.
Yeah, thank you, Ellen. And welcome, everyone. Really excited to have all of you here today, and really excited to be kicking off this particular program. For those of you who don't know me, emergency department testing is near and dear to my heart, since it's something that I worked on for 10 years prior to coming to CDPH. Next slide. And part of the reason EDs are so near and dear to my heart is because, as you all know, emergency departments are a safety net for HIV-infected individuals. They're often the sole and only point of entry into the healthcare system for HIV-infected individuals, but as you'll soon see, also for syphilis and Hep C infected individuals. And the rollout of HIV testing in emergency departments prior to COVID paralleled the decline in individuals who were undiagnosed with HIV, meaning we identified more folks so that we decreased the amount of folks that were undiagnosed with HIV in the US as ED testing rollout occurred. Next slide. And all of you are well aware of the situation with primary and secondary syphilis in California. Historically, California has mirrored what has happened in the US, but more recently, around 2012, 2013, California's incidence rates for primary and secondary syphilis began to exceed those of the US. And by 2019, which is that little peak here, we were double the incident rates of the US. Next slide. And we saw a similar pattern with congenital syphilis, where around 2012, 13, CS cases began to rise in California. And by 2020, they were almost double those of the US. Next slide. So as we faced these growing cases of syphilis in California for both primary, secondary, and congenital syphilis, we added some supplemental questions to California's state disease investigation, surveillance database, asking individuals, where did you access care or support services during your pregnancy? Just a minute. So sorry. And 24% said emergency departments. I am so sorry. Sorry, next slide. And just to show you why emergency departments are so important. I'm sorry, I've got something in the back of my throat. All of a sudden, you can see that this is some data from Bakersfield Memorial Hospital ED, who has given me permission to share this data multiple times previously, where you can see that the positivity rate in routine screening for syphilis can range anywhere from 5 to 10% in the emergency department. Next slide. And similar data for hepatitis C screening in their emergency department ranges anywhere from 5 to 9%. So as you can see, emergency departments are a critical place to find HIV, syphilis, and Hep C infected individuals. And what you're going to find, and I'm so sorry that I cannot really talk today, what you're going to find is that you're often going to find those individuals that you've been looking for months and have been unable to find, that they're showing up in your emergency department. Okay, I'm going to turn this back over. Sorry, I don't know what's going on. Apologize.
No problem. Thank you so much, Dr. Jacobson, for that wonderful welcome. To dive a bit deeper and ground our conversation today, we wanted to share a little bit more background on some of the key focus areas of the EDSP project. And I do want to note this will likely be a review for most folks on the call, but we wanted to start off with reviewing a bit of why we're here today. Next slide, please. So first, why syphilis, HIV, and hepatitis C? I won't spend much time on this slide since I know I'm joined by many HIV, Hep C, and STI subject matter experts in the room today. But to briefly summarize, syphilis and congenital syphilis rates are rising in California, and California has a significant chronic hepatitis C and HIV burden, with many folks who remain unaware of their status or untreated. In addition, syphilis and hepatitis C are curable, and treatment can render HIV undetectable and untransmittable. And lastly, there's overlap or a syndemic among disproportionately affected populations and transmission dynamics. Next slide. And next, why does this project focus on emergency department settings? Well, as many of you know, and as Dr. Jacobson highlighted, for those who experience barriers to routine care, EDs are often the sole point of contact with the healthcare system, and EDs truly reach patients where they are at. Next slide. In fact, several evaluation studies that have been published by EDs across the country on this topic have found that ED screening programs can first result in increased diagnoses of syphilis as well as other asymptomatic STIs. It can also reach a population that otherwise may be missed through traditional screening recommendations. And finally, potentially avert cases of congenital syphilis. Next slide. In an evaluation study completed in Miami-Dade County, the ED enhanced their routine HIV and hepatitis C opt-out screening infrastructure to include a syphilis smart screening algorithm to identify patients for routine syphilis screening. And 16 months post-implementation, the algorithm triggered 4,806 syphilis tests, and 122 patients, or 2.5%, tested positive. Out of those 122 patients, 59 were confirmed positive, and in total, the screening program prevented 9 cases of congenital syphilis. Next slide. EDs may also play a critical role in reaching individuals with undiagnosed HIV. One driver of HIV transmission is that approximately 1 in 10 people living with HIV in California have not yet been diagnosed. Because HIV-infected patients visit an ED at more than twice the rate of the general population, and they may serve as the primary source of care for marginalized individuals most at risk for HIV infection, the routine offering of an HIV test in the ED can be an effective means to diagnose, link, and re-engage patients in care. Next slide. And finally, hepatitis C specific studies have found that 11% of ED patients in an urban ED in California reported a history of injection drug use, and that undergoing a blood draw did not increase the length of stay. In addition, they found that 10.3% of patients tested hepatitis C antibody positive, and that half of patients were previously diagnosed with Hep C, but many were out of care. Next slide. And finally, why opt-out testing? Opt-out testing is recommended as best clinical care by CDC and health departments, regardless of reported risk behaviors, and it's an effective strategy to identify infections, begin immediate treatment, link to care, prevent transmission, and promote health equity. And next, I'll pass it back over to you, Cynthia.
Wonderful. Thanks so much. So let's step next into centering the program goals. Next slide, please, Paco. They are first to identify and immediately treat those at highest risk, to next help control these epidemics statewide and reduce morbidity and mortality. And we want to improve health system capacity. So we do this through our commitment to 24/7 care access and by linking patients to both health care and community services. And we want to further health equity and reflect our commitment to social medicine. In the next slide, I want to note it's EDSP funds and supports sites across a range of implementation for routine opt-out screening in the ED setting. So in the cohort group of funded sites, we have a rich mix of experiences with and plans to implement expand or sustain screening. So for example, we have sites who are brand new to opt-out screening, and will be brand new to partnering with you all. We have others who are sustaining programs. And I want to note that we also have many sites expanding programs. So for example, an emergency department who is currently routinely screening priority populations may utilize the funds and support to expand that opt-out screening to every ED patient who receives a blood draw. Next slide. So what are we expecting of EDs that participate? Hopefully it's clear we're expecting them to begin or sustain ED opt-out testing for syphilis, HIV, and HCV. And so that means, what we mean by that is to test and begin treatment, provide patient education, and link patients to follow-up care. So really critical in the work that they will be doing with you all. And the EDSP model utilizes this syndemic approach rooted in person-centered and trauma-informed care, in racial and social justice, in harm reduction, and in health equity. And this really seeks to address not just social drivers of health, but the interaction and overlap among disproportionately affected populations and transmission dynamics. So on the next slides, let's look a bit at the awardees in an overview. I want to celebrate as we do that this California state appropriation of funds is the first of its size nationwide. And I want to note that we had an overwhelming response to the RFA. So 73 EDs applied for this highly competitive funding opportunity. And so you and your colleagues may also have EDs in your jurisdictions who are interested in this work, even if they were unable to be funded through EDSP. Next slide. On the map, we can see, and dropped in the chat, the funded sites throughout your region and throughout California. We'll also drop the list if you prefer a spreadsheet version of just the list of the sites. And I want to note that this geographic distribution reflects the RFA and the application evaluation process. So the needs-based scoring criteria in particular prioritized a health equity approach to reach those most disproportionately impacted. And the distribution's emphasis on the Central Valley in particular was driven by a focus on preventing congenital syphilis and on earlier identification of HIV infections. So you can also see that the cohort characteristics meet the goals of the state funds, which were to have a diversity of low, medium, and high volume EDs in terms of annual visits, and to represent both rural and urban settings. In the next slide, I will overview briefly the current testing practices among EDSP funded sites. The source for this data were their applications. So going from left to right, starting on the far left, we have in light purple, those only doing diagnostic testing of symptomatic patients for each infection. Next, in darker purple, we have those screening priority populations. Then in cranberry, screening all populations who receive all patients who receive a blood draw. And last in orange on the far right, those doing universal screening. And so from this data, we can see that a larger percentage of EDSP funded sites are doing only diagnostic testing and screening of priority populations for syphilis as compared to current practices for HIV and HCV routine opt-out testing. And so really what we know is there's a range of where EDSP participants are starting in terms of testing practices, and we see a lot of potential for expanding screening reach through EDSP. I want to note too that many sites are already doing or plan to start ED-based treatment, which, as we know, critically increases equity and access and continuity of care. And also that on top of this syphilis, HIV, and HCV work, 9 EDs expressed interest in adding routine opt-out screening for chlamydia and gonorrhea, and 1 plans to implement Mpox vaccination in their ED as part of the program. So next, I will just briefly mention that the EDSP resources for EDs. So throughout the 2.5 years of fundings, we will have webinars and trainings for ED clinical staff. They will cover key implementation topics from patient navigation to creating processes and protocols. We had a kickoff webinar with the EDs last month, and also provide ongoing coaching a dedicated patient navigator community Slack channel, and access to this repository of resources to support this work. So feel free, if you haven't already, to scan that QR code or follow the link in the chat to see the resources that are available. And note that we'll continue to add to that repository over the course of the project. So I'll go ahead and pass back to Ellen.
Great, thanks so much, Cynthia. We can move forward to the next slide. So in addition to formal webinars and trainings, we'll also be hosting a monthly ED community of practice, as we've heard over and over that having ED to ED conversations is a facilitator to implementation. So the ED community of practice will serve as a more informal space where ED providers can chat with other providers about best practices, barriers and potential solutions that they're experiencing, and ways that EDs can partner with their health departments. ED attendance is optional and rolling, so ED staff can drop in when they're able or if they have a particular barrier that they'd like to chat about with other emergency departments. And I do want to highlight that this community of practice is a space for both EDSP awardees along with other EDs in California that may be interested in implementing a screening program. And given that the community of practice is intended to be a space for ED personnel to connect, local health department staff will only be invited to attend select community of practice meetings that will focus on the partnership between EDs and health departments on syphilis, HIV, and hepatitis C prevention. Next slide. As a part of this program, EDs will also be participating in data collection efforts to support two reporting goals. First, data collected from EDs will support an evaluation of EDSP as a whole. And this evaluation will focus on the process of implementation by outlining best practices, lessons learned, and program models, the outcomes of the program by determining if implementation of opt-out testing is an effective strategy to increase testing, identify positive cases, and link positive cases to care and treatment. And lastly, an assessment of whether screening in this setting reaches some of the most underserved communities. Second, data collected from EDs will support reporting back for ongoing program improvement, and these data will be reviewed and analyzed in an ongoing way throughout the program to help emergency departments understand and improve their programs. Next slide. Now let's transition to the focus of our call today, the local health department and ED collaboration. Next slide. At this point, you might be thinking, how does all of this impact local health departments? So we wanted to highlight some of the benefits to local health departments on this slide. So EDSP may benefit local health departments by fostering relationships and partnerships between local EDs or hospitals and public health. EDSP may also support local health departments in identifying newly diagnosed and previously diagnosed but out of care individuals, and beginning treatment and linking patients to care whose sole point of contact with the healthcare system may be in the ED, thereby reducing missed opportunities and decreasing local morbidity and mortality. And ultimately, EDSP may support local health departments' goals in advancing health equity. Next slide. So what do local health department and ED collaborations look like in practice? Listed here are a few models that we've seen in California that highlight collaboration between EDs and local health departments. So in the first example that you can see here on this slide, the linkage to care navigator is based in the emergency department and conducts follow-up and linkage to care, consulting the local health department for diagnosis, testing, and treatment information as needed. Next, in this next model, you'll see that the disease intervention specialist is based at the local health department and receives referrals from the ED and provides follow-up and linkage to care. This typically requires daily communication between the ED and the health department. And lastly, you can see that there are several local health departments, one of which you'll hear from today, that have embedded DIS in the emergency department to provide follow-up and linkage to care. And as a reminder, these are just a few examples of ways that we've seen folks partner. Ultimately, regardless of the specific process that's implemented, it's critical that prior to rollout, EDs and local health departments determine standard operating procedures for linking patients who test positive to care, including identification of who at the hospital, clinic, and/or health department will ensure seamless linkage to care so that patients don't fall through the cracks. Next slide. As I mentioned, we'll hear from several health departments shortly who have partnered with their EDs to support this linkage to care piece. But generally, we've heard that there are several models for local health department collaboration and some key staff that typically support this work at the health department. So firstly, there's a staff member to assist with linkage to care at the health department. This individual receives regular communications from the ED, like data, reports, or phone calls, to collaborate on linkage to care, ensure treatment, and support partner services. The staff member also follows up with ED navigators to communicate outcomes of linkage to care and treatment as appropriate and feasible. Note that there's typically 2 linkage to care staff involved in this process, but not always. One linkage to care staff is typically based in the emergency department, and one is based in the local health department. Next, as you can see on the slide, there's a medical provider at the health department who's available to answer complex patient management questions. And finally, there's someone from surveillance or partner services that supports treatment and partner services through historical diagnosis and treatment record searches. Next slide, please. And with that, I'd like to introduce our health department panelist speakers for today. So we have Dr. Sharon Wang from the San Bernardino County Public Health Department, and Patrick Salazar and Shantell Waldo from the Kern County Public Health Department. So welcome, Dr. Wang, Patrick, and Shantell, and thank you so much for your willingness to share your experiences partnering with EDs on the call today. Before we dive into the discussion, I do want to note that our panelists will be responding to several questions during the panel discussion today. And we'd encourage, like Cynthia mentioned, to write any questions that you have for them in the chat. And then we'll plan to circle back to those questions at the end of the call today when we have a Q&A. So with that, next slide, please. We have our first question for our panelists today, which is to describe how you collaborate with EDs on linkage to care and partner services. So first, I'll invite Dr. Wang to share their experiences in San Bernardino, and then I'll pass it over to Patrick and Shantell. So I'll pass the mic to you, Dr. Wang.
Thank you. And while you pull up the slides, thank you so much for the opportunity to get everyone together to talk about this really important topic. And so just to give a little background, our county hospital, Arrowhead Regional Hospital, is a level 1 trauma hospital. It's our county hospital serving the community. We have around 450 beds, and Arrowhead actually started the opt-out testing back in 2017. So they have already had opt-out testing, and when they started implementing opt-out testing, they were doing 70 tests combined a month, and then after the implementation, the volume went up to over 1,000 a month, combined syphilis, HIV, and Hep C. So it makes sense. The next step is to partner with public health to strengthen that linkage to care piece. So I don't know if the bridge team has the slides. If not, I can screen share mine.
Paco, if we could move to slide 43, please.
Right, so we all know the purpose of the opt-out testing, and the inception idea actually started at Arrowhead Regional, their infection control. The inception idea was in 2019. There's a conversation between our then STD controller and infection control nurse at Arrowhead Regional. They were just having a conversation about patients. And then the idea was, what if you have a CDI working in our ED, helping us answer all these questions? And so that was the inception of the idea. And then we all know what happened between 2020 and 2023. So that project, that idea took a pause, and we resumed the conversation spring of 2022. There were several virtual planning meetings, and then finally we got our staff oriented and onboarded February this year. And with that process, it took about a month, and then we started having our CDIs or DIS working at their emergency room in February. Our staffing were funded through EHE, Hep C, Health Education Fund, STD HIV grant through CDS. We started gradually, so our goal is to have at least 2, if not 3 full-time FTE DIS in the ER, but we started slow. We started with getting 2 onboarded, and we gradually increased their hours. We started at 2 days, and then we moved to 5 days, and now we have 6 days coverage. Right now we have about 1.5 FTE. Again, our goal is really get to that 2 to 3, so we can provide coverage most of the time. And how the time was determined, you know, some of it based on our staff's hours, some based on the traffic of the ER. When do they anticipate a heavy traffic? And next slide. Yeah. So again, the goal really is to establish that clear expectation. How can public health help? You know, we can help with education, not just with the patients, but with the clinicians, with the providers, provide education linkage to syphilis, HIV, Hep C, gonorrhea, chlamydia. And that we all know with STD, especially syphilis, providing that historical data on lab and treatment history is critical in providing a comprehensive care. We do offer HIV PrEP prophylaxis and doxy-PEP education. I know at least in our ER and our primary care setting, still HIV PrEP uptake is low amongst primary care and ER. Contact tracing of the partners, we get that direct history from your patient zero, where do you hang out, things like that, face-to-face. I think that face-to-face visit to get that comprehensive network of partner is key. We also offer mobile STD treatment after their discharge if they need services. So kind of help link them to our available public health services. And then also just what infectious disease they have questions about, or STDs, I should say. Because next thing you know, you are the public health. They ask you for everything. They ask you for salmonella. They ask you for that. So just clearly define, I am here as the STD support. Next slide. Okay, keep going. Okay, so again, the one thing that I stress with our team is we're there to support. We're not there to replace their current system. How they register, how they triage the patients, everything is the same. It's once the opt-out testing results are back or patient comes in with STD complaints, we hope that they will consult us and use us as a resource. So again, this workflow process, it mirrors their current system. Next. Again, the ER physician, and again, this has to be made clear. The ER doctors are still responsible for the full care of this patient. The ordering, the disclosure, the education, all of that is still the primary physician or clinician's responsibility. We are there for support for education after. So this question came up, the reporting of the condition for Title 17 requirement, that still falls on the hospital. That is still the hospital's responsibility. The disclosure, that initial disclosure still falls on the attending or the clinician seeing the patient. But again, we're there, we can follow in afterwards to do all the counseling, but that initial disclosure is still the ED's responsibility. Next. And again, this is a pictorial depiction of kind of the workflow. Again, the goal is we look at the positive result. Either we have a way to look at the positive results, or we get consulted when patients come in for STI complaints. CDI meets with the patient. Again, usually it's after the patient's being worked up for their acute care needs, or while they're waiting for testing or for treatment. That's when we go in. Again, we try not to impede the workflow. And then we will help that linkage to care piece. I think that is very important to clearly define if you have this patient with this insurance or lack of, where do you go? And then the treatment, again, be the pair of eyes be the pair of eyes to ensure treatments are provided based on STI guidelines. Again, we can do intervention in real time. Next slide. And our CDI's responsibility, again, these are all clearly defined in an MOU. Our CDI's responsibility, when they show up, they check in with the PA and the triage nurse on shift schedule, let them know, hey, we're here to help. We worked it out with infection control. So there's an infection control tab, all the positive results. Our CDIs will review them and review the medical record to see what needs are. Is a patient admitted to the hospital, still in the ER, or discharged? And again, in the ED, we interview the patient, get sexual history, provide a CD education, discuss other wraparound services, and inform the patient and treatment that's needed. Again, that linkage to care piece is important. Next slide. Okay.
All right, and actually, instead of jumping to the next question, and thanks so much, Dr. Wang, for sharing your experiences, but instead of jumping right into the next question, I'll actually pass the mic to Patrick and Shantell to describe their processes for partnering with EDs on linkage to care and Kern.
So hello, everybody. My name is Patrick Salazar. I'm a program manager here at Kern County Public Health. So we're excited to share some of our experiences with collaboration. Like Dr. Wang just discussed in her talk, we actually share a lot of overlap with the way that San Bernardino does a lot of their collaboration with the ED. I think some of the notable differences with us is that they have the ability to embed CDIs into the hospital. That's not how it works here in Kern County. We actually, through a program called Focus, the hospitals here, Bakersfield Memorial Hospital, which was the first to start the project back in, back in 2019, when they rolled out their project. And so they were actually able to hire linkage to care navigators for their project. And so it just made sense that we, as the health department, were the experts. We already were doing linkage to care work for all of these different disease conditions. And so we kind of came in and we're providing that support and some of that training to kind of help them understand how some of these different things worked. And so we started doing that with them in 2019 when they were funded. And then in 2020, before the pandemic hit, Adventist Health Bakersfield started their routine opt-out testing in their ED. And so very not long after Bakersfield Memorial Hospital started their project. And so we were kind of all in it together, and we had to develop some communication flows as part of Focus so that we could have some kind of process in order on how the ED linkage to care navigators were going to notify the health department team as part of any positive results that came out of that screening at both hospitals. So what happened on our end as part of Focus, we were funded to hire CDIs on our end to also be that communication with the linkage to care navigators at the hospitals. So anytime a positive result came in through the hospital, navigators were communicating with us on, just like Dr. Wang, any prior disease history, including syphilis or HIV, and any hepatitis C. And so we had communication flows as part of that process. We also, what we ended up doing as part of trying to streamline our communication, because what we were finding is that sometimes we weren't getting things real time, like real time communication. And so what we ended up doing is, as part of this whole process, is we developed MOU. Initially, we had to develop MOUs anyway to share information and share data. But as part of that process, what we decided to do is we implemented a better communication system for us to do that real time. And so we ended up utilizing the platform Microsoft Teams. For our department, since we are a healthcare agency, we had to utilize something that was already in place for our department that was HIPAA compliant, that had encryption measures. And so we were able to implement Microsoft Teams. And so we developed teams for each hospital. And then we were able to assign a CDI to each hospital that would have communication with the linkage to care navigators. And so anytime a result came back positive, the linkage to care navigators would drop that information into our Teams channel to be able to say, you know, real time HIV or syphilis, or sometimes all three. And our team was able to respond with treatment history and any other pertinent information. The hospital was also able to share the medical notes for any patients as part of that communication. And so we're many times we were also able, like San Bernardino, be able to provide transportation for any patients. So if they started treatment in the ED, they were able to send them over to us, to our public health clinic, to finish their treatment if needed. And then also, I think what also was helpful is that we were able to actually go out to the ER. If the patients were admitted into the hospital, we were actually able to go out there and talk to the patients and really start initiating that linkage to care. And then also we were able, EDs were able to send folks to us if there was a positive HIV result. They were able to send them to us, to our health department clinic, to begin rapid ART treatment. If they're negative, try to get them on PrEP services. And so it was really helpful to have that communication. Shantell, do you want to add anything?
You know, that the communication part, getting that in place before, I mean, if you listen to all the things that all the hospitals that are working with doing linkage to care with public health, it's like a dream date, right? All that information, we have a ton of information, they have a ton of information. You know, we love to leave the office and we'll go out to the hospital and talk to someone. We'll do whatever needs be. You know, we also have we also do in-field notifications, because sometimes people leave AMA or they leave without any contact information. And so we, you know, I know that worries providers when they can't tell someone they have an HIV positive. We go out and look for them, because we're doing it anyway. But just getting that linkage to care team and your public health team together to start that communication from the beginning, because the amount of cases we've seen here, it's overwhelming sometimes. And we are fortunate that we have amazing hospital partners, linkage to care partners, and each of my CDI are just work with one hospital. That's because of the massive caseload. So they know each other, they know about their families, you know, over this time period. They have these great relationships that help with all of this. So just getting that communication in there, we stay in our lane, they kind of stay in their lane, because hospital culture is very different than public health culture, and we do whatever it takes to get it done. So we're very, very proud of that. But if you're starting this, you know, make sure that your team is cohesive and is working and communicates regularly, like every day. So
And yeah, and I forgot to mention that we have another hospital, Kern Medical, that just started doing, they're still trying to get it off the ground. They've been doing manual testing, but we're trying to, you know, implement the same process with Kern Medical. And they are very high volume. They used to be our county hospital. And before they migrated over to being what's called a hospital authority. And so, but they're the main hospital that takes in a lot of the patient volume in our county. So it'll be interesting to see how that plays out. And so we're trying to build up our support on how we're going to facilitate that collaboration with Kern Medical, but using the same model that we've been using with Bakersfield Memorial Hospital and Adventist Health.
Great, thanks so much, Patrick and Shantell. I think I'll move us forward to the next question that we had for you all, which is to generally describe how collaboration for linkage to care and partner services has been going, and in particular, you know, what successes and or barriers you've experienced, and if you've experienced barriers, how you overcame them. So I'll pass it to you, Dr. Wang, to kick us off.
Thank you. So, lots of meetings, lots of meetings, and if you can have my slides up. Okay, so we have to look at things that are measurable. And so these are some of the things we pick out as part of our end of the day CDI survey. We looked at how many appointments are scheduled, patient interview, patient education, provider education, and set infection control status, which I'll go a little bit more in depth. And again, as you can see, it's a very slow start. We started in February. This is only from February to June and not full time. So appointment schedules are those that we actually made the appointment for the linkage to care piece. Next slide. This is just another way of looking at the same data. And you can kind of see the fluctuation between week to week. Our goal is to hopefully see it uptrend. Next. Okay, so this is for those that use Epic or Cerner, you know, this is the storyboard. And when our CDIs or when the county infection control team, when they look at a patient's positive syphilis result, they will call us, or our embedded CDI are on site. They will set the infection status. So the storyboard, that's the Facebook, that's like the face page that when you log into Epic, and it has the alert, infection, and we have one that says syphilis, and it'll be highlighted, treated or untreated. And if you hover over it, it has a blurb of the detail as to their previous titer or treatment, and a recommendation, or and again, usually we provide some kind of staging and historical data, and then some kind of treatment recommendation, treated or untreated. So again, it's training the providers, training the residents to look at don't just ignore alert. I know we all get that alert fatigue, and you just dismiss everything. But again, we are on site, we train the residents and the nurses, the providers, the attendings that look at that. So that now that's the first thing that they'll look before they pick up the call to call our CDI or call our infection control nurses. So we find this the most helpful, and our team spends a good amount of time doing this. Next slide. And then we looked at linkage to care by infection and also the percent positive. So since we started, we picked up around 10% of HIV positivity, syphilis was 8, and then Hep C was 3, that we were able to link. We're still figuring out how to link patients to Hep C care. Often there's not a method of linking them directly from the ER to the ID doctor or the hepatologist. Usually it goes through primary care first. Next slide. And again, it depends on the disease process. You'll have this kind of a protocol. If you have this infection, this is how you do it for HIV. We encourage rapid ART or early ART. Usually our goal is to get them linked and started on treatment within 7 days, whether that's linking back to their primary care doctor or directly to an infectious disease or to public health, our HIV easy access clinic. Same thing with syphilis. We have options to refer them, and what also what Patrick had mentioned, we also have our field team that will go out for those who are unhoused or difficult to get to primary care doctor. We will link them to our mobile team to go out and do the bicillin injection. Same thing with gonorrhea and Hep C. Next slide. This again, it's just different way people look at it differently. It's different table of our productivity. Next slide. So I'll turn it over to Patrick.
Great, thanks, Dr. Wang. So in terms of successes, very similarly to San Bernardino, what we really were taken aback by, and we kind of were expecting it, but not to the multitude that we did. The hospitals really, because of the screening, they really identified many acute cases of HIV. And it was really astounding to see how many that they were identifying, which, as you all know, is like, it's good and it's bad, because it's bad because we don't want to see that, but good in that it was identified early because they went to the ER. And we were very fortunate, especially during COVID, that these projects had just launched and then COVID hit. And so then nobody was really going and getting healthcare. People were going to the EDs because they were having COVID symptoms or other issues. And so the hospitals were identifying folks even through COVID that were testing positive for syphilis, HIV, and hepatitis C. And so it was really amazing to see, really seeing that dynamic happening during COVID. And so we always joke all the time, even now after the COVID emergency, people were not social distancing. And so, but it was really amazing to see how many acute cases that the hospitals were identifying. And so obviously that's great for us to be able to identify them early and get them into services early, get them into treatment early. And so, so when we did this project, we had just gotten our rapid ART program off the ground. And so the fact that these two programs were happening at the same time was just a blessing because of the cases that were coming out of the ED, and the EDs were still trying to also find their footing with now identifying these cases, and now what do we do with them? Well, we're here, health department is here to help do that and provide that support. And so I would say that was like a really big success, and not just that, but like demonstrating like this is why this exists. Like this is exactly why this exists. And so it was a great way to kind of also demonstrate that back to the hospitals, because the hospitals were just still kind of in that unsure phase, like, okay, we're going to do this. And we realized the importance of this, But when it really comes down to it, like there's still that nervousness there about identifying somebody who's HIV positive, and now what do we do with them? And so that was a really great, that was something really great that I felt came out of this as part of developing that partnership together with the hospitals. Shantell, what would you say are some of our other successes?
Definitely 2020, we did all this work from home pretty much. So we were disclosing, treating, the hospitals. We had very limited services at public health, and the hospitals, what we were working with them to make sure somebody needed 3-by-Cillin, they were back at the hospital. They worked really hard together. We're getting people treated. So we got people treated. We got people into HIV care. It was a learning experience, and it's something I'm super proud of with my team in the hospital, and the hospitals themselves. Like, they never stopped. There was never an option. We're doing this, and that's what it's the best thing to do. We're gonna do it. We've had so many successes just with human successes. When we were in 2020, we were doing everything with our phones. We were just like, hi, doing FaceTime on our phones. And, we've tried really hard through this project to establish that if you ever find yourself out of care, or you lose your insurance, or anything happens that you can't get your HIV care, call us, call this number, because long after we're gone, there's always going to be someone here to help you. There'll always be someone that'll get you back on track. And just recently I had a lady come in, and they're like, oh, someone wants to see you. And I went into the exam room, and when I opened the door, she's like, you told me if I get lost, I come here to see you, and I'm here. And I was just like, oh, hey, and it happens all the time. We're really proud of like establishing that they've helped us get people back to us that need to be there. Right. There's so many good things. Just being able to, my linkage to care staff in the hospitals at first had a really difficult time with provider buy-in and nursing buy-in. So they would get food and put them in backpacks, and they would walk around to every nurse on shift and go, hey, my name's Jessica, we're doing this project, so when you see that up there, that's what this is. And they give them food and or coffee cards, and everybody loved it. So they worked really hard on getting the buy-in on their side, which could be at first was kind of difficult. And so they talked to the providers. They're always putting things up around, there's a bicillin shortage, and remember, they just work so well with us, and we've been very, very fortunate with having kind of the same team members for the duration of this project. So I think that's pretty much.
And I would just really quickly add, I know we're going over time. I think one of the other successes that came out of this is, obviously us and everyone else in the state have been having issues with, high congenital syphilis rates. And so one of the things that Adventist Health did is they embedded a linkage to care navigator in their L&D department to kind of be able to really get things real time and making sure things are going appropriately from the L&D department given congenital syphilis.
Great. Yeah. Thanks, Patrick and Shantell, for sharing all of those experiences. And Dr. Wang for sharing your experiences as well. I think I'll move us maybe to the third question that we had for you all. So our last question that we had for our panel is, what advice would you give to other health departments that are thinking of implementing a similar process? So I'll pass the mic over to Dr. Wang.
Okay, and if I can get my slides up, but I will remember bringing muffins. If my CDIs are on, take notes, bring muffins to the nurses. Note to self. So again, just really quickly, get the stakeholder involved early on, identify an on-site champion. Again, our goal is to teach the team how to fish, not to cook the meal for them or whatever analogy that is. But again, it's really to empower them. So when we leave, when we are, not that we're going to, but oh, I don't know, but we're there to empower and teach them this STI treatment, education, linkage to care process is to stay at the hospital, at the ER. This process is created even when we're not there. So really identify that on-site champion. We have a very support ER leadership, and they've identified a physician assistant to be that on-site champion. We hold monthly meeting. We used to be bi-weekly, and then now is monthly. We identify any fallouts, get the nursing leadership buy-in as well, the C-suite leadership. And also, most important, if you are healthcare system, have residents, have medical residents, family medicine, IM residents, or even OB residents that are interested in doing projects, have them shadow the CDIs, again, because we are new to their healthcare system. Having that on-site resident shadow our process, give us feedback is very important. Infection control, if you do decide to embed, decide which hospital department is going to house the credentialing and all of that. We pick infection control because the idea came from there, and it just made sense at our county hospital. IT, clinical informatics, get them involved from the get-go. That was our pitfall. They were involved with the opt-out since 2017, but there was a switch with Epic, and we didn't get them involved early enough. So there was a little bit of delay in rolling out, but they can help build your documentation, help build the order set, help build the consult order. What kind of drop-down menu do you want for the indication for consult? And then also access to the infection control storyboard. Media team, advertisement is really big. We continue to have low consult. So our team goes to the medicine, the family medicines, didactics. Our team have given lectures at their department staff meetings to, again, just to word of mouth and advertisement. We will talk with their case management, their social worker services to see what kind of existing linkage to care services they already have in existence. So we're not recreating the process. So that's pretty much, that sums up all the people you need at the table. Yes. And again, it's just, again, understanding the challenges were the EHR, learning the EHR, and then again, coordination between different departments. Like I said, there's a lot of meetings, and then that on-site champion really can help pull people together on the hospital side. Thank you.
So for us in Kern, obviously, we as, all of you that are with the health departments know, like, as part of, disease reporting and things like that, we need the information that we need, and that's always gonna be what we have to do as a health department as part of our responsibility. And so being able to have this relationship with the ERs really, really helps facilitate getting that information so much easier, because there's a partnership there. And so I think for us, in terms of like advice, I really think it's just all about fostering that the relationship with the EDs to let them know, like, here's what we can do for you. We don't want this to be a burden. We don't want this to be something that's more work for your staff to do. Just like Shantell was saying, like, and even Dr. Wang, like, you have to get everybody's buy-in and support for this. I remember we were even having meetings with like some of their billing department, because they're like, well, how are we going to do this? Like, how do we work with the health plans, that we're billing people's insurances for? And so we had to even go and try to, it went beyond just us and the hospitals. We had to take it to a whole new level to also involve like other partners that needed to be aware of this. So health plans, other community health providers, because they needed to be aware of all of this, of what was happening, so that one, they know what's going on. Two, if these patients are needing to go to them for if there's people's PCP, or if we're trying to connect them to other linkage to care and health services, it was important to communicate with providers, especially infectious disease providers, because they needed to be aware of this is what the potential volume that may come out of these ERs for positive results. And so that ended up being the case with HIV. We were really identifying more people, unfortunately, that were testing positive. And so the infectious disease providers needed to be aware of that, of what could be expected. And so we really had to try to think of all the different community partners that had a stake in this, because it just went beyond just the hospital and the health department. And so that is something that I would recommend you all as health departments try to do with your EDs or within your jurisdictions. Shantell, what else would you say would be some advice?
In that work that Patrick's talking about with the ID providers, we have a couple providers that we can do same day appointments with now. Our time connecting to care is a lot of times about a week. Within a week, we can get people into the providers. So that's been a huge success there. But I would say the most important thing is like be very clear about, this is what we do, this is what you do, and have clear expectations of that, how you work together, because that's very, very important. So you're not duplicating work, so you're not getting in each other's way when it comes to the linkage to care persons. You're only as weak as the information that you collect for patients. And part of the problems that we have with our linkage staff, or our linkage staff have, and we have, is the admissions department. When someone's being admitted, they're like, okay, is everything the same here? And they would click yes. So it would say homeless 999. So there'd be no emergency contacts, nothing, just a name. And sometimes not even the correct date of birth. And so working with every point of contact with that person, our linkage to care staff are like, so where is it you hang out? Where do you take a shower? They have a whole thing that they go through that they give us now, because they want to make sure that we can find them if we have to find them. We have a face-to-face meeting once a month that has made everything completely different with our linkage to care people. We sat down and say, hey, we're having a problem. This hepatitis C provider is impacted. We have to do this, all of the things that are making any hiccups come along. We sat down face to face, have lunch together, and work it out. So that's part of why everything has been, it's not easy, but easier than it was. And then I guess finally just collect data, that know the data, what you need, public health needs, and what the hospital needs, and collect it the same way, because a lot of stuff is going to come out of this. So be aware of what needs to be captured and how you capture it, and capture it the same way with the same definitions. And we circle back once a week for every person that's came through the hospital to make sure we haven't missed anything. So just checking and rechecking every part, because there will be so many when you decide to, when this happens, the amount of patients increase incredibly. So just work together, and you'll get it done. So
Great. Thank you so much to you all for such a rich discussion and sharing so many helpful tips and your experiences back with the group. I think I'll move us forward into the next kind of portion of the webinar that we were hoping to chat a little bit in more detail about, which is how local health departments can leverage their grant funds to support this work. And before I do that, I do want to note that if you have any additional questions for any of the panelists today, like I mentioned before, feel free to add those into the chat. And then after a couple more slides, we'll dive into our Q&A portion of the call, and we'll circle back to some of those to address them. So next slide, please. All right, so to support syphilis, HIV, and hepatitis C screening, I do want to mention that local health departments can connect with their local EDs to explore possibilities to partner to fund this work and leverage existing funding from CDPH. So we've included a list of STD Control Branch grants that could potentially support ED-related activities on this slide. The first activity is funding a patient navigator or disease intervention specialist at the health department or embedded in the ED to support linkage to care. And another activity is funding testing program costs, such as testing supplies, testing equipment, and staff time to conduct the testing. It's important to note that there may be administrative restrictions on funding, such as an ED nonprofit status. And so if you do have any questions about how CDPH grants could be leveraged to support this work, please feel free to reach out to your STD Control Branch grant manager or regional capacity building coordinator to explore this a bit further. And then beyond STD Control Branch funding, EDs and local health departments could also consider exploring other federal initiatives or county general funds, among other possible funding sources. Next slide, please. And finally, I want to touch on resources and technical assistance that we at the STD Control Branch could provide to local health departments to support this work. Next slide, please. All right, so what support or technical assistance will be available to local health departments? So firstly, we can provide individualized technical assistance calls with emergency departments, local health departments, or both. Next, we've also developed some materials, including an intro slide deck and a resource guide, which highlight the importance of screening for HIV, hepatitis C, and syphilis, along with different models or lessons learned from other EDs across California. And we're happy to facilitate or co-facilitate those calls with emergency departments to walk through the intro slide deck with them and answer questions and brainstorm around this topic. Additionally, we're happy to facilitate connections between your health department and other local health departments that have partnered with EDs on this topic to discuss things like workflows or standard operating procedures, successes, and additional lessons learned. And finally, your DI liaisons are available to support technical assistance related to DI work that will result from this program. And your regional capacity building coordinators are available to brainstorm around utilizing grant funds, like I mentioned, to support this work. I also want to highlight that we're happy to support technical assistance needs on this topic for health departments who would like to engage with both EDSP awardees and or non-EDSP emergency departments. And lastly, if there's any additional ways that we can support you all in this work, we definitely want to hear about it. So please feel free to reach out to let us know if you have any additional thoughts or ideas. And my email address will be coming up later in the slide deck, and I'll put that in the chat. So feel free to email us if you have any other thoughts or ideas. And with that, I'll pass it over to Cynthia, who will facilitate or guide us through the Q&A portion of the call.
Great. Thank you all so much. This has been such a rich discussion. I want to just highlight that there's been some questions and answers about lab turnaround time in the chat, and move on to a next question. And I think, Dr. Jacobson, if you're willing, I'll start with you on this question, which is about what do you all recommend for the challenges of HCV care being so separate from HIV and syphilis? So the questioner called out differences such as being in a different division and treated by different partners.
Sorry, I'm trying to get off mute. You know, where HIV care is heading is really test to treat, just like everything else. And so in the ED, those separations don't per se exist. And the data is mounting to move to test to treat for Hep C. So from an emergency room standpoint, you know, they'll do the testing with the results. They can potentially treat based on preliminary results that we have to, there's now data supporting that even. And then they refer to the appropriate either, you know, I don't know how much Hep C test or treatment is actually occurring in the public health departments versus a local clinic, but a lot of times you'll develop partners through various clinics who are willing to accept the positive patients through the ED. And so the public health department's role would be to help facilitate both those connections. If you're aware of a clinic in your area that's doing that work, of course, if you're doing it, fine to do it in the public health department, but also to help facilitate that linkage to care via the disease investigator once the patient leaves the ED. I don't know if that really answers your question, but I think it's because we're in a place of transition, much like we were in the earlier days of testing it for HIV in the ED, moving to test to treat.
Thank you so much, Dr. Jacobson, and the, you know, we will share this with EDs and their upcoming planned webinars as well, just to say that. And did any of the panelists before we move on have anything that you wanted to add about your experiences regarding this kind of current and changing division between HCV and other infections? Okay.
And maybe just to add that we're accumulating the articles out there that are sharing some of the data of test to treat. I don't know if we've shared them with your team, Cindy, to post on your website, but we can if we haven't already, so folks have access to those.
Great. And I'll just read out, thank you for the comment in the chat that in terms of increasing coordination and breaking down silos, encouragement for integrated STD, HIV, and HCV huddles within the ED health department in the same way that Shantell said the navigators do in the ED settings. So that's a really great tangible suggestion as well. Thank you for that. I know we folks, the panelists touched on this already a little bit, and is there anything more that either the panelists or our partners wanted to share about successes or lessons with using like health alerts and automated mechanisms for communication?
Hi, it's Patrick. I was trying to get myself off of mute. So for us, I think for us, it really goes back to, it's a double-edged sword, because obviously with us here at the health department, because of the way our model is set up, we're only here 8 to 5, you know, Monday through Friday. And so, so we don't really have communication outside of that. So if something comes in after hours, we're able to pick up the next day, or if it's on a weekend, what we try to do is we try to we've already provided the hospitals like our after call number, so which our epidemiologist staff are on call number, and so we also involved like our epidemiologists on what was going on. So in case they needed to tend to a matter that was after hours for whatever reason, they would be able to do so or provide information. And so we really tried to provide resources so that the communication didn't just completely stop. But other than that, we just rely on our Microsoft Teams communication to get some of that real-time communication that's happening with patients in the hospitals. And I think the only other thing I would add is in regards to one of the things that we've done that we've been grateful for because of this project is we were able to really catch with our congenital syphilis program. If we had a pregnant woman on the radar and she was getting ready to deliver at any moment, our PHNs were able to send delivery alerts out to some of the different hospitals. But because we had such a close working partnership with Memorial and Adventist, we would get some of that real time like communication that's happening, giving us like the heads up that, hey, she's here, she came in for whatever. So we were able to kind of funnel that communication back to the PHNs, so that we were kind of all on the same page. And so I would say really that Microsoft Teams has been really, really helpful with real-time communication connection.
Yeah, our hospital staff are really on the congenital syphilis alerts for us. There's a pregnant person here, they have syphilis, so they blow it up. Either they're calling on the phone or they're on Teams because they just want to make sure that that everything goes right and that person gets treated, or they make sure that the right protocols are in place.
Right, and really just having that boots on the ground CDI also helps our entire department, our other CDIs working cases, because sometimes they would say, oh, this patient is actually at RMC, and then we have our own eyes, boots on the ground at the hospital. I do want to say one thing about Hep C, again, having such a low uptake of treatment is really doing that education with your primary care physicians. Again, this should be a primary care disease that primary care doctors can be equipped to manage, and then also working with your major health care service for your county if they still have requirement that says Hep C, you need to refer to specialists, GI or ID, and work with your big insurance carriers to change that. Thank you.
Wonderful. Thank you all so much. And I just want to also add broadly to just reassure and maybe excite you all that the ED awardees are getting the same messaging about the importance of collaborating with you all and the expectations there, and the expectations for them to engage stakeholders throughout each of the implementation milestones that we are supporting them through. Go ahead, Ellen, to if you would wrap us up.
Wonderful. Thanks so much, Cynthia. We can move on to the next slide. Wonderful. So in terms of next steps, we'd really encourage local health departments to meet internally to discuss how your health department can support your EDs, and reach out to your STD Control Branch grant manager or regional capacity building coordinator to explore leveraging grant funding to support this work if needed. Next, we'd encourage you all to reach out to any EDSP awardees in your jurisdiction to set up a meet and greet. It's important to note that the ED may not be familiar with the type of support or services that public health provides. So it may be helpful to provide a general overview and talk in more detail about how you can support linkage to care. You all should have received an email with the EDSP ED contacts and emails, but please reach out if you'd like support in making those connections. It may also be helpful to begin discussions with the emergency department about setting up standard operating procedures, as we heard from our panelists today, for linkage to care. So things like what will your standard operating procedure entail, and who specifically will be responsible for which pieces. And then start drafting your standard operating procedures with the emergency department. And finally, throughout the process, feel free to reach out to either Bridge or us at the STD Control Branch as needed. And lastly, on the next slide, you'll find my contact information, so my email address. So if you have more questions, feel free to send them my way. I know too that there was a request in the chat for MOU examples or protocols. So if any of the panelists or other folks on the call that have partnered with EDs in your jurisdiction have any shareable resources that we can distribute or disseminate, feel free to send them our way as well, and we'll make sure to include that in the follow-up email. Other than that, I know we're coming up to kind of the end of the webinar today, so I just want to really thank everyone for joining. I think that this was a really wonderful kind of discussion and kickoff to the EDSP project. And like I mentioned, if you have additional questions, don't hesitate to reach out.
Thanks all. Take care. We'll cut out now. Have a nice day.